Welcome to This Explainer. Okay, I am absolutely thrilled you're joining me today because we are looking at a massive, ground-up paradigm shift in acute kidney care. For over a decade now, we've relied pretty heavily on the 2012 KDIGO guidelines to manage acute kidney injury. But, kidney injury has changed. Well, not because the kidneys suddenly became more dramatic, although anyone who has managed ICU oligoria at 2 a.m. might respectfully disagree with that, but because our understanding of it has matured so much. Today, we're walking through the 10 major changes and the 4 distinct directions of care coming our way in the 2026 KDIGO draft guidelines.
All right, let's dive right into this. The old 2012 mindset did a great job standardizing diagnosis, but it largely treated AKI as this delayed, reactive, 7-day isolated event, relying heavily on a trailing functional marker, serum creatinine. The 2026 mindset? It completely flips the script. It moves us toward a predictive, proactive, and connected journey. We are no longer just sitting around waiting for function to drop. We are integrating structural markers of cellular stress across an entire continuum.
And really, that brings us to the core philosophy of this update, the kidney continuum. The central message of this entire draft is beautifully simple but totally profound. AKI is no longer just a short, inpatient creatinine event. It's a warning signal, it's an incredible treatment opportunity, and it's a long-term risk marker. It recognizes that acute injury spans recovery, recurrence, and bridges right into the risk of chronic kidney disease.
Now, to make sense of all these amazing updates, we've grouped the 10 major changes into these key areas: the paradigm shift, diagnosing earlier, stratifying risk better, actively protecting the kidney, and finally, ensuring a safer recovery. Section 1. The paradigm shift, understanding the new framework. So this paradigm shift brings us to our first major change, stepping beyond just acute kidney injury to officially include acute kidney disease. AKD is defined as kidney dysfunction or damage lasting up to 3 months. Guys, this is a huge conceptual upgrade. It captures patients who might not meet those classic rapid 7-day AKI criteria, but who still have clinically meaningful unresolved injury. Think of things like a slower fall in GFR or persistent albuminuria. It reminds us, hey, do not declare victory just because the acute hospital admission is over. Kidney injury has an afterlife, and AKD is very often that quiet bridge walking a patient right into chronic kidney disease. Let's move to Section 2 and see how this builds. Diagnose earlier, functional and structural information. Within this expanded framework, obviously, we still value serum creatinine and urine output for that acute 0 to 7-day phase. But let's be honest with ourselves. While creatinine is cheap and familiar, it's late to the party. It's a trailing indicator. And in frail older adults, patients with muscle wasting, or the critically ill, creatinine can actually significantly understate the problem because of dilution or low muscle mass. Because of this, the new guidelines advocate for adding serum cystatin C whenever creatinine might be misleaded. Which leads us right into the second big change, structural biomarker-based thinking. We are now integrating markers that measure what the kidney actually suffers. Functional markers like creatinine measure what the kidney does, right? But structural criteria like urinary TIMP2 multiplied by IGFB7 or urinary NGL, these detect early tubular cell stress and active damage way before the function even starts to fall. But, and this is a pretty huge but, the guidelines offer a very grounded caveat here. They remind us that these biomarkers are incredibly helpful, but they aren't magic wands. They shouldn't be used as random kidney astrology. You have to use them in validated clinical settings like major surgery or sepsis to identify patients who are at risk of moderate or severe AKI. Now, the third major change is a much more granular staging system. AKI is no longer just stage 1, 2, and 3. There is a crucial 48-hour dividing line now. We actually separate transient AKI, which resolves within 48 hours, usually after a bit of volume resuscitation, from persistent AKI, which simply refuses to yield past that 2-day mark. Clinically, this is vital. A patient with persistent AKI carries a significantly higher long-term risk and absolutely mandates much more rigorous follow-up. Moving right along to Section 3, stratify risk better, validated models and clinical context.
Here's the fourth major change, a much stronger emphasis on risk prediction. The guidelines highly recommend using externally validated risk models to guide shared decision-making. But the absolutely crucial step here is local calibration. Listen,
A predictive model that performs brilliantly in one hospital-specific patient population might just sulk quietly in the corner at your hospital. They have to be rigorously tested and systematically linked to predefined response protocols locally.
And speaking of systematic responses, the guidelines issue a really practical warning. They explicitly recommend against isolated, interruptive creatinine-based electronic health record alerts. Why? Because recognition without a protocol is totally useless. Without an actionable pathway, these alerts just cause massive alarm fatigue. They're literally just noise with a pop-up window. We've all been there.
Now, what's really interesting about this next part is our fifth major change, a return to a highly proactive diagnostic approach using both brand new dynamic tests and old reliable tools. The guidelines are putting three specific tools right in the spotlight. First up, the furosemide stress test, which is a fantastic dynamic way to assess tubular function and predict if early-stage AKI is going to progress to the point of needing dialysis. Second, kinetic eGFR, giving us a much more accurate estimation of function when a patient's creatinine is wildly fluctuating. And third, good old urine microscopy. It might be totally unfashionable these days, but identifying those muddy brown granular casts remains an incredibly practical, hands-on way to diagnose intrinsic tubular injury.
Section 4. Protect actively, interventions, and stewardship.
All right, let's talk change number 6, fluid and hemodynamic management. Here's the rundown. For initial volume expansion, do use crystalloids. Do not use colloids like starches or gelatins. And within those crystalloids, buffered solutions are highly preferred over 0.9% saline as your default. Now, if a patient has severe metabolic acidosis, the draft suggests using IV bicarbonate rather than reflexively rushing to immediate renal replacement therapy. And finally, target a mean arterial pressure above 65 in critically ill adults and strongly avoid low-dose dopamine. The guideline puts a firm nail in that coffin. I think we can all agree the kidney has suffered enough from the low-dose dopamine myth. Changes 7 and 8 are all about shifting our mindset from just reacting to a rise in creatinine to proactively removing harm. In high-risk patients, the guideline recommends a multi-component kidney protection strategy, optimizing volume, managing glucose, without aggressive tight control, mind you, and using diuretics strictly to manage fluid overload, not to somehow cure the AKI itself. It also places a massive emphasis on stronger drug and nephrotoxin stewardship. Pharmacists are highlighted as absolutely vital team members here, engaging in sick day protocols and stopping offending agents before the damage multiplies. Change number 9 addresses what is arguably one of the most stressful decisions in the ICU, dialysis timing. The KDIGO guidelines recommend deferred timing of renal replacement therapy over early preemptive initiation. To put it bluntly, and I love this quote, do not treat the frightening creatinine, treat the patient. We shouldn't be starting dialysis just because a lab number looks scary on the screen. The recommendation is to wait for medically refractory complications, things like uncontrolled hyperkalemia, severe metabolic acidosis, or significant volume overload that just will not respond to medical therapy. Obviously, this doesn't mean delaying dangerously, but it means letting the clinical symptoms, not just isolated numbers, drive the decision.
Which brings us to our final pillar, Section 5, safer recovery, follow-up, and long-term care.
So the crucial point is this: acute kidney care absolutely does not end the moment the patient is discharged. This brings us to change number 10, which is arguably the most patient-centered update of them all, structured follow-up. Step 1 is review. Discharge summaries must explicitly detail the AKI episode. Step 2 is restart. We need to move away from permanently withholding beneficial drugs out of fear. Safely resume medications like RAS inhibitors or SGLT2 inhibitors based on guidelines. And step 3 is monitor, executing a critical 3-month kidney health check, assessing eGFR and albuminuria to track recovery and catch any transition into permanent CKD.
And this brilliantly illustrates the entire 2026 mandate. The KDIGO updates move us in these 4 integrated directions: diagnosing earlier with functional and structural information, stratifying risk better with validated models, actively protecting the kidney with smarter fluids and stewardship, and following patients after discharge for a safer recovery. We are finally recognizing that AKI is a warning signal, an intervention window, and a long-term risk marker. The 2026 KDIGO framework makes it clearer than ever. The kidney is telling us something earlier, louder, and for a lot longer than just 7 days. It is literally giving us the structural clues before the function even drops. The science has matured, the guidelines have evolved, and the real question leaving this explainer today is this: are our clinical systems actually ready to listen?
Thank you so much for joining me, and I highly encourage you to review your own protocols against this fantastic new framework.